All right, today we're going to look deep inside the brain at something that's often called a ticking time bomb. It's a rare and pretty complex condition. We're going to break down exactly what it is, how doctors even find it, and the incredibly tough decisions that have to be made afterward. Okay, let's get into it.
Okay, picture this. You go in for a brain scan, maybe for something simple like headaches, maybe for nothing related at all, and the doctor comes back and says they found something unexpected, a weird tangle of blood vessels that just shouldn't be there. This is the exact moment a very high-stakes medical detective story kicks off.
So what is this thing, this tangle? Well, it has a technical name, an arteriovenous malformation, or just AVM for short. And to really get what that is, we need a super quick crash course in how the brain's plumbing is supposed to work.
So think about it like this. Normally, you've got these high-pressure arteries that carry blood, and they branch out into this huge, delicate network of tiny vessels called capillaries. These little guys are crucial. They slow the blood down and deliver oxygen to all your brain cells. Then, the blood flows into the low-pressure veins to head back to the heart. An AVM, though, is a chaotic shortcut. It's a direct connection from a high-pressure artery straight into a low-pressure vein, completely skipping that all-important capillary network. And that creates a seriously weak spot with a ton of pressure. And here it is. This is exactly what that faulty plumbing looks like. This crazy, tangled-up knot of vessels right in the center, that's called the nidus. It's the absolute heart of the AVM. This is where that powerful, high-pressure arterial blood is just slamming into these weaker veins that were never, ever designed to handle that kind of force. Remember this image of the nidus, okay? It is the #1 clue doctors are searching for.
So the moment a doctor spots one of these tangles, the real detective work begins. Because finding a suspicious-looking spot is one thing, but correctly identifying it, that's a whole other level of challenge. Because here's the kicker. Not every tangle is actually an AVM.
To figure it all out, radiologists basically use a decision-making map, a lot like this flowchart here. Now, don't worry about reading every single box, just get the big picture. You can see it's a step-by-step process. It guides them through a whole series of questions based on what they're seeing on the scans to make sure they land on the right diagnosis.
And the very first fork in that road, the first big question they have to answer is this: do we see a compact nidus? You know, that tangled knot we just looked at? Whether that thing is there or not sends the entire investigation down two completely different paths.
And you can see just how clear that difference can be. I mean, it's night and day. On the left, you've got that classic, tightly wound nidus of a true AVM. But on the right, well, you see a bunch of abnormal vessels, sure, but it looks totally different. It's way more spread out, it doesn't have that central compact knot. And that distinction, it means everything.
Because that thing on the right, that's what we could call an imposter. It's a condition that might look a bit like an AVM at first glance, but it's fundamentally different. And so is the prognosis. And there are quite a few of these lookalikes.
So the radiologists really have to put on their detective hats to rule out these common mimics, like a developmental venous anomaly, or something called moya-moya disease. Each one of these is treated in a completely different way. If you get the diagnosis wrong, you could either perform a risky, unnecessary treatment, or you could fail to treat something that's actually really dangerous. The stakes are incredibly high.
Let's just compare an AVM to the most common mimic, the developmental venous anomaly, or DVA. An AVM is an abnormal, dangerous shunt, but a DVA, it's just considered a normal variation in how the brain's veins formed. It's just different. Now look at that bottom line. That's the whole ballgame. An AVM often needs treatment. A DVA never does. So you can see why getting this right is absolutely critical.
And here's that DVA up close. Radiologists have this amazing name for it. They call it the caput medusae, which means head of Medusa, because all those little veins drain into one bigger vein, and it looks just like the snakes on Medusa's head. It's a really striking image, and thankfully, a totally benign one.
All right, another mimic has an equally cool name, moya-moya disease. It's a Japanese term, and it literally means a puff of smoke. And you're about to see exactly why.
And boom, the moment you see the angiogram, the name makes perfect sense. See, moya-moya isn't a tangle. It's a blockage of the main arteries going to the brain. So the brain, in this amazing effort to survive, grows this whole new network of tiny, fragile vessels to get around the blockage. On the scan, that network looks just like a hazy, delicate puff of smoke.
Okay,
So, let's say the detective work is over, the imposters have been ruled out, the diagnosis is confirmed, it is a brain AVM. Now comes the part that really matters, assessing the danger. How risky is this thing?
So, what's the big deal? What is the real danger here? Well, the reason it's called a ticking time bomb is the risk of a hemorrhage, a brain bleed. But here's the thing. Not all AVMs have the same risk. Some are way, way more likely to rupture than others. So how on earth do doctors tell the difference?
Well, they have a checklist. They're looking for specific red flags in the AVM's architecture. Things like, are there tiny, weak, balloon-like spots called aneurysms hiding inside that nidus? Are the veins that are draining the blood narrowed or restricted? Is the AVM located deep inside the brain? All these features help them calculate the risk.
But out of all the factors on that list, there is one that stands head and shoulders above all the rest. The single biggest predictor of a future bleed is a past bleed. If an AVM has ruptured once, the risk of it happening again goes way, way up. That one piece of history changes the entire conversation.
So all of this, the diagnosis, the risk assessment, it all leads to the final and, frankly, the most challenging part of this whole journey, deciding what to do next. And the choice isn't just about getting rid of the AVM, it's about carefully balancing the risks of the AVM itself against the very real risks of any treatment.
And it really boils down to 4 potential paths. Sometimes, for a lower-risk AVM, the safest bet is actually to do nothing, just watch it and wait. For the higher-risk ones, the options get more invasive. You've got open neurosurgery to physically take it out. There's a less invasive procedure to go in through the blood vessels and plug it up with a special kind of medical glue. And then there's radiosurgery, which uses highly focused beams of radiation to scar the vessels and close them down over a long period of time.
Which path you choose totally depends on the AVM's specific characteristics. So, for example, take a look at this one. It's small, and it's right on the surface of the brain, not buried deep inside. That makes it what doctors call a grade 1 lesion. And it's a perfect candidate for surgery to just remove it completely, with a pretty low risk of complications. Now, a giant AVM deep in the brain, that would be a totally different and much more difficult story.
And that brings us right back to the central, incredibly difficult question that every patient and doctor has to face. How do you weigh the known risks of a major brain surgery against the unknown future risk of a ticking time bomb inside your head? There's no easy answer. It's a profound, deeply personal decision, and there's no single right path for everyone.